Good afternoon, everyone. We're going to go ahead and get started. I know we don't have quorum, but I can see that we have all the kids who are trying to sit in the back of the class are sitting next to Chief Garcia. I don't know what that means, but if we could just start at this end, and we're going to all just introduce ourselves, and then the clerk will let us know when we have quorum. It's also a good way to get the mics. Just to test the mics too, to see if you know how to use them. Yeah, there you go.
Kishan Vajini, representing South Bay Consortium for Adult Education, as well as San Jose Green Community College District.
Amanda Clifford, formerly Justice Involved.
Erin O'Brien, Community Solutions.
Key Lee, Supportive Housing.
Aaron Johnson, Pretrial Services.
Judge Vanessa Zecker, Supervising Judge of our Criminal Division.
Judge Stephen Manley, Superior Court Judge.
Miguel Marquez, County's Chief Operating Officer.
Cindy Chavez, member of the Board of Supervisors.
Patricia Lucas, Superior Court.
Matt Guerrier, Executive Director, Custody Health, Custody Behavioral Health.
Molly O'Neill, Public Defender's Office.
Eddie Garcia, Chief.
Tony Tully's Behavioral Health.
Thank you. We're going to move then to our public comment, and this is for anybody who would like to speak to an item that is not on the agenda, but within the purview of the committee, and we'll invite up Scott Largent.
Good afternoon, morning, Merry Christmas. I get a lot of stuff that shows up lately at my house, so I'm trying to process all of this and get up to speed on becoming my own lawyer for my own legal defense, because I don't get representation in civil court, getting clobbered by the city of San Jose. So this has been a fun experience, and just like my experience of fighting to be in my daughter's life, you have to, remember I said this kind of hypothetically one time in here, you have to break the law to be able to see your kid. So if I went out in that parking lot and knocked somebody out, ended up out at Elmwood, they would protect my parental rights and make it happen so I could see my daughter. So it's kind of weird that you have to do that to make things happen in our county. And it looks like I have to do the same thing to get a quality legal defense. So currently right now, I'm in civil court where I shouldn't be, in front of a judge that ruled against me. Actually, I think I have it in here, ruled against me on a writ that involved getting my bullhorn case thrown out. So I don't understand how Helen Williams could not recuse herself, how I couldn't recuse her for cause. I mean, it was just, I was just getting clobbered in there. I mean, there was nothing that I could do in there. And what was really hard is I asked for some more time. I said, hey, I've got pending charges. And I said, Your Honor, Helen was not having this, okay? And then I asked her, well, wouldn't you have to recuse yourself since you get your marching orders from Patricia Lucas, our presiding judge? And Patricia Lucas had me arrested out in front of family court for protesting. So I thought it was really weird. Those charges are still pending right now. So that's where it gets really confusing. So how could I not have more time? You know, how come I could not have a legal defense? So I tried every single thing I could do, and it just doesn't work out. There is currently an injunction right now that prevents me from disturbing the peace out in front of your police department, Eddie Garcia. Now, if I violate that injunction, you guys ready for this? I then get assigned legal counsel from the IDO. So I don't want to fight the city myself in there right now. So what I'll do on Christmas, Eddie Garcia, is I'll be out in front of your police department like I do every Christmas. And I bring out all my daughter's toys, and I bring them all out in front of there, and I let all the officers know how bad I hurt. And that's why I'm out in front of there. And I tell them why this police department wouldn't enforce my visitation orders. They wouldn't look into any of my community complaints. And that's why I'm out in front of there. And I wonder which one of your officers will be the one to arrest me out in front of there on Christmas. I will be out there protesting, okay? I'm not going to back down to you or the crooked regime from the city of San Jose. And that's what I have to do to get a quality legal defense. That's a load of shit in this county, and I'll tell you that. I'm going to keep fighting and keep putting me in that jail. Keep trying to do it. I got rights.
Thank you, Scott.
Thank you. Happy holidays.
So we're going to move back to item 3 is to approve our consent calendar. We don't have quorum yet, so I'm going to come back to that. But we'll move to item 4, and this is to receive a report from the Office of the County Executive relating to the implementation of a Gilroy Fire Emergency Medical Technician Paramedics Pilot Project. And if you could just introduce yourself as you begin to present would be great. Thank you.
Hi there. I'm Ken Miller, and I'm the medical director for the Santa Clara County Emergency Medical Services Agency. And here we go, I think. Very good.
Pardon me for one moment, Doctor. For those of you who have screens in front of you, you might be able to hit input a couple times and get the presentation right in front of you.
Yeah, and I'll talk you through it. I see that some of the algorithms are kind of small on the screen, so I'll just talk you through those. So as I introduce this, let me take you back a little bit for some history, back to 2014, to explain where these pilot projects came from. Back then, the California EMS Authority and the California Office of Statewide Health Planning and Development, or OSHPD, used a program under OSHPD called the Health Workforce Pilot Project Program to organize a series of projects that allowed EMS to operate somewhat differently than what state statute permits, which specifically goes to destinations for 911 EMS transport. The categories of those pilot projects you have in front of you there were several categories: public health, there is one for high-risk hospital discharge, one for frequent 911 callers, one for hospice, but the one that was caught our attention going forward was those projects that allowed alternate destinations. Alternate meaning destinations for 911 EMS other than acute care hospitals, which currently is specified in state statute, which dates back to the 1970s. In that time frame, from 2014 on, a project similar to ours was formed in Stanislaus County. They also were working on a project with behavioral crisis and a sobering center. Fast forward then to 2017, the EMS Authority and OSHPD were interested in expanding these programs and offering other sites to engage. So we did engage. And we used some existing data that we knew from 911 EMS transports and behavioral crisis and sobering from South County to propose a project to EMSA and OSHPD that goes to alternate destinations for patients on a 5150 hold and for patients who are clinically intoxicated. We engaged patients beginning about April 2018, which places approximately 12 of these projects now throughout California, with Santa Clara County being one of the newest for behavioral health and sobering, and with San Francisco being one of the newest for sobering centers. I believe somewhere in that mix is also Fresno County, but I'm not sure if they're up and running just yet. Nationwide, there's approximately, and this is pretty much an estimate, but approximately 129 community paramedicine programs spread around about 33 to 34 states. That's the best estimate I can find based upon an EMS survey from about May of this year. There could be hundreds of these around the country that might be very small, but projects like ours and others that are larger are the ones that responded to the survey. So it gives you a perspective on what's going on out there in a larger picture. This is a summary of some findings from a July 2018 report by OSHPD. While you look that through, let me talk you through a couple of or several of the objectives for these pilot projects, specifically in our case for behavioral health, behavioral crisis, and sobering centers. One of the big ones is to affect the change in state statute, as I mentioned, relative to destinations that are permitted for 911 EMS. I'll come back to that one in my conclusions in a few minutes, and we'll discuss that a little bit further. Other objectives include local law enforcement, behavioral health, and EMS agencies in discussion then for alternate solutions to patients on 5150 holds and for transport destinations. Crisis intervention, outpatient behavioral health, inpatient psych facilities may become destinations for 911 EMS. And then the larger picture, community paramedicine and mobile integrated health can be a broader initiative which can better bring together integration between EMS and the healthcare systems. So a key portion of this, of any project, and indeed a guiding principle in medicine in general, is patient safety. So I thought I'd address this right up front and show you the elements of this project that address patient safety specifically. So the project is anchored around a protocol. That protocol looks at a variety of aspects of the patient, and I'll show you that in a second. It was developed from the available medical literature, but also in coordination with Stanislaus County and Mountain Valley EMS Agency, who had been doing now a project like ours for some time, for several years. So we took advantage of their experience and developed our protocol in coordination with them, as well as the medical literature. The local institutional review board reviewed our protocol as well for approval. We conducted education with the Gilroy Fire Department, firefighter paramedics. The EMS agency conducted that along with behavioral health and discussions regarding behavioral crisis and uncomplicated alcohol intoxication. Because our system, our EMS system, is electronic, we are able to do 100% case review pretty much as soon as a patient is encountered and data entered into our pre-hospital patient care record. That record then is closed once the patient is transported to a destination. That data becomes available to us to review. So we have almost real-time capability of reviewing cases as they're entered into the study, which gives us good visibility, and those cases are reviewed by 100%. Medical oversight is local. It's by me and the Santa Clara County Emergency Medical EMS Agency. There is immediate follow-up should a patient be transferred from one of the destinations to a hospital emergency department. We had one case, which I'll mention to you briefly in a second. And then finally, the state, through the EMS Authority and OSHPD, have contracted with a third-party independent reviewer for all of the pilot projects, including ours, as a data review and a data safety manager. So we have external oversight of our own processes. These next two algorithms simply talk you through quickly how this thing looks from an operational point of view. These are 911 EMS cases. In the case of behavioral crisis, they are patients who are placed on a hold by law enforcement. We have a brief questionnaire that goes to law enforcement about the circumstances leading up to the hold placement. And then our community paramedics have a protocol that leads them through a treat and refer set of criteria. If the patient is determined to need medical care of some kind, then of course they're transported to an ED, an emergency department, like we normally would anyway, and collect data from there. If they do meet the criteria within the protocol, they're transported to, in this case, the emergency psychiatric services, where we can collect data on length of stay, discharge disposition, if there is the emergency department referral, what that is and for what reason, and then discharge diagnosis, which will be interesting, and I'll show you those in a second. On the sobering center side, it's a very similar strategy. Again, they're 911 EMS patients. They are presenting with a history consistent with uncomplicated alcohol intoxication. They are assessed by the same protocol and same criteria. If they do need medical attention, they are transported to a hospital emergency department. If not, they would be transported to the sobering center. Now, I'll point out that it's interesting and perhaps not surprising that when law enforcement encounters a patient who is intoxicated to a degree where 911 fire EMS is engaged, they tend to be too intoxicated for the sobering center. So we've had no transports from the field anyway to the sobering center so far. We've adopted the same criteria as a sobering center, and we'll keep surveilling and see if we find candidates, but so far they've proven to be too intoxicated for that particular route. The protocol, in brief, goes through four basic categories. Patient eligibility is first reviewed by looking primarily at vital signs. Exclusion criteria go to clinical presentation to be sure that there are no comorbidities of medical and trauma problems. We review behavioral crisis factors to be sure that there are no underlying medical or trauma causes for behavioral changes. And then, as I mentioned, we've adopted the sobering center criteria for eligibility for acute intoxication. So I'll skip this. This really is just putting it all together, but you've already heard the key points, and I'll get to what I think you're probably most interested in. So this is a quick flyby, a 30,000-foot view of our first 75 patients. And so my disclaimer is the numbers get small with some of these patients. It's too soon to draw conclusions, but there are some trends that are interesting, and we'll be pursuing as we go. So these are 75 patients who were transported from the field to emergency psychiatric services. Their median age was 22 with a broad range. Their length of stay was 10 hours. The median length of stay was 10 hours, again with a broad range. Their discharge disposition, half of them were discharged to self, home, or family, meaning they didn't require any immediate follow-up care. The other half were discharged to a broad variety of outpatient, residential, or inpatient facilities. The mix is pretty much even, male and female, although that does change based upon discharge diagnosis. And then among the diagnoses, so for simplicity or convenience here for our conversation, I grouped some things together. Going forward, as our case number increases, we'll be able to have a little more specificity on these diagnoses. But in doing that, a trend is emerging that I think is interesting. So about between two-thirds and three-quarters of the patients encountered so far in this pilot project had a discharge diagnosis of adjustment disorder, meaning that they were behavioral and emotional symptoms associated with identifiable stressors. Their median age was 19 with a median length of stay of about 10 hours. For more serious mental disorders, schizoaffective disorder, which is a combination of symptoms between schizophrenia and mood disorder, their median age was a little bit greater, 32, with a longer length of stay. Bipolar disorder, also a little bit older, not much, but with a short length of stay. And then depressive disorder, a median age of 15, with a short length of stay. I mentioned that we had one ED transfer. That was interesting in that it was the only patient who had the probable cause for a 5150 hold that was greatly disabled. The others were all danger to self or danger to others. That patient had underlying health considerations that, although they weren't manifesting acutely at the time, they complicated the assessment. The firefighter paramedics underwent extraordinary measures in order to get adult protective services involved and take care of the patient. They were seen in a local emergency department, treated, discharged, and then APS followed up as outpatient later. So what we've learned from that is to largely patients who present now with a probable cause of gravely disabled, we'll pretty much treat as medical patients first and move on and move from there. So far, so good. So let me conclude, and then I'll take your questions on one of the key issues and one of the key objectives of pilot projects like this. Since the 70s, there have been statutes that have driven EMS practice in California, and one of them is the requirement for transport to an acute care hospital. In the legislative cycles of 2017, 2018, several bills were introduced, I believe at least 6, give or take some. And they had various objectives. Some included all of the current pilot project types I mentioned earlier. Others were specific to behavioral crisis and sobering centers. There were, as you can predict, variable stakeholder organizations who opposed or supported. And all failed. All failed either in committee or withdrawn by the author. The importance of the legislation is that it would drive then change in statute that would give us, as EMS agencies, latitude to find solutions to patient care that may go beyond or destinations beyond that of acute care hospitals. The bill of interest, and the last one in 2018 was AB 3115. It encompassed all the pilot projects. It added several layers of oversight, both at the state level and the local EMS agency level, which had an interesting effect on shifting some of the stakeholders' opinions from opposed to support and vice versa. Ultimately, it was vetoed, but the veto letter from the governor include instruction to OSPID to extend all the pilot projects, including ours, through November 2019. So we have one more year of data collection to go, either pending successful legislation or pending extensions further of the pilot projects. So let me end there, and let me see what your thoughts, and if you have questions, I'll try to work through them with you.
Great. And what I'm going to do, I wanted to make sure folks knew, is that part of the reason this got presented to us was actually a request from Gary. I think is Gary here today? Oh, yeah. So Gary Hersig wanted to make sure that we knew that this was happening. And I really appreciate, Dr. Miller, you being here because it's all tied into the work that we're doing. So we're really excited to hear about it. So I'm going to just start on this side and I'll go down the road. Aaron, you look pent up with questions.
A couple quick ones. Doctor, so 75 screened in is qualifying to go to EPS. How many were screened in total?
Oh, good question. There were, I don't have that in front of me. There were probably on the order over 100 that were screened. There were about 2/3 or so of those that we screened wind up being eligible. The other third are excluded because of some underlying medical condition or at least their presentation requiring medical evaluation.
We'll keep Judge Manley. And could you grab his? Yeah. Thank you.
Thank you for your presentation. I wanted to ask you, you mentioned that no one was taken to the sobering unit up here because they didn't meet the criteria. What are the criteria that would exclude them from that option?
Yes, basically the operating criteria for the sobering center is the patient, the client needs to be more or less self-functional. They have to be able to do their own transfers, go to the bathroom on their own, for example, and be reasonably functional even though intoxicated. The patients that we encounter with law enforcement when law enforcement needs fire EMS help are far beyond that relative to the level of intoxication. So it really goes to, I think, to a patient safety issue where the monitoring of a patient at that level of intoxication is more intense at a hospital as opposed to the sobering center, and that's the overriding reason why we had no candidates yet.
And who makes that judgment?
The Mission Street Sobering Center has their own set of criteria.
No, but I mean, in terms of out in the field.
The paramedics do.
The paramedics do?
Yes.
Okay, and you have trained paramedics with you. Just on this issue, we have the sobering station here. What do you think about the need for a similar facility in South County? Because if I understand reading all this, you have the Gilroy Fire Department, and so they would have to be transporting all the way to San Jose.
Mm-hmm. Yes, that, and if the patient presents really with uncomplicated alcohol intoxication, that's taking up valuable resources of emergency departments. So it contributes to some degree, and I can't give you a percentage, but to some degree overcrowding in EDs as well. So using a protocol that assures patient safety, and that's going to be key, there would be value to reducing the impact of the effect of intoxicated patients' arrival at hospital EDs, yet providing a safe environment for that person to be cared for, attended to, and to sober up until they're safe to be discharged. The concept of sobering centers is picking up nationwide, and there are some fairly high functioning ones. Some of them, for example, are also licensed clinics, and therefore have a higher level of medical provider care available to the patient or client. The value there is patients who are somewhat more intoxicated can be safely taken there. So part of the discussion is to judge what level of patient care a community feels they would like to engage, and therefore drive somewhat what level of patients and intoxication an EMS system can safely take there.
Okay, thank you. Two other questions. One, when you say intoxicated and use that term, are you seeing in these 75 that you've seen just alcohol, or are you seeing drugs as well? I mean, I saw drugs this morning. I see it every day in the courtroom, people that are totally intoxicated, not able to do anything for themselves. Mm-hmm. But so what percentage of these were drug, because it relates to the mental illness or the behavioral disorder? what percentage were drug and what percentage were alcohol, if you know?
Well, we're making judgments based upon clinical presentation. So
Okay.
it would be difficult in many cases to discern what, if there were indeed polypharmacy going on, what other drugs were involved beyond ethanol. Now, there are some toxidromes that present that, you can begin to infer other toxicants over and above ethanol. But for the most part, our patients are evaluated clinically and not toxicologically. Similarly, patients who are brought even to the ED, emergency department, may not need toxicological evaluation in order to affect their clinical care. So there isn't a whole lot of data on everyday clinical practice anyway, outside of studies, that you could use to exemplify, how many patients we encounter who have the clinical effects of both alcohol and some other, let's say, depressive drugs. There are probably many. But as long as those patients meet our criteria for safety, even that polypharmacy can be acceptable.
But what if did any of these 75 or 100 people that you interacted with, were any of them totally drugs and no alcohol, no ethanol?
Probably not, in that the toxidrome of ethanol, which is what we're looking for really.
Okay.
Other toxicants probably produce symptoms that will alter mental status sufficiently that they wouldn't be safe candidates for destinations other than the emergency department. And unless drug analyses were helpful in some way to clinical care of that patient, they typically aren't done either in clinical care. So it's a little hard to nail down what other drugs are involved. If there were other depressant drugs, as long as the patient can be assessed to be safe, that can be okay.
All right. A final question. In these findings you gave us of the 75, and I noticed in your boxes on that graph, you have the ultimate destination as they end up somewhere, and then on this statement you say that 48 of these people, of these individuals, went home or family or self. And then at 52% went elsewhere. Do you know where they went and did they get there? Because that's something we're struggling with. So you put them at wherever, the emergency room. Do you know if they actually had a discharge plan that was followed through? Have you gathered, or are you gathering that data?
Yeah, we know the discharge disposition relative to the intended follow-up. So, for example, there are any number, and there is quite a number of options for outpatient behavioral health, for inpatient psychiatry, or for residential destinations.
Right.
Once we have more cases, we will be able to perhaps characterize better outpatient versus inpatient disposition and residential dispositions relative to diagnoses. What I think the important trend here so far is that half of our patients who are transported there are assessed to be safe enough to be discharged to self, with perhaps and probably some outpatient care, at a later time. The other thing is that a large proportion are diagnosed with adjustment disorder, which suggests that alternatives to crisis intervention may have value in reducing the number of patients required to be on a hold or otherwise be transported by EMS at all.
Mm-hmm. Thank you.
Key?
Just a quick question. I think you stated that 100 persons were screened and then 75 were transported to alternate destinations.
About that.
Does that mean that you captured all potential persons who could have been screened during this period between April of 2018 and now, or do you think more?
Probably so, because we chose a scope of a project that was intentionally fairly small, so we could do just that and maintain pretty strong parameters and oversight of the project. So it worked out that a patient population in need was in a jurisdiction with a well-defined public safety provider with whom we could work closely. That means that we are probably capturing, at least through 911 contacts, all the patients who have the potential for being eligible From there, we have to do our assessment and see who can be safely engaged and who need to be treated more and transported more traditionally.
So then I'm wondering kind of what are the implications of this? So if we're saying 3/4 or 2/3 of the folks can be diverted, what are the implications for the ER or the system? And what happens, I assume that the legislation is kind of looking for a way to take it to scale, and kind of what happens if we can do that?
Sure. Several layers to that. So the most immediate one would be that if EMS systems using a protocol that can be proven to be safe can transport patients to destinations other than acute care hospitals and find those destinations, within a particular community, a health system, that would be a big step toward personalizing care for patients other than the one-stop shop of acute care hospitals. So that's sort of like the first and maybe the simplest thing. Beyond that is having conversations within communities, within healthcare systems, and among all of us as to what other resources might be made available to law enforcement, for example, to help to deal with patients who have perhaps a behavioral crisis, but not really a mental illness. And how those patients might be handled differently than either an inpatient facility for a while or even an outpatient facility at some point later. There may be opportunities for crisis intervention that might begin to solve some of the behavioral challenges in the moment and offer solutions, in the short term. So I think your question goes to really where I think we all want to have conversations and to find solutions is what can we do better as a health system, as an EMS system, and as a community to meet the needs of patients rather than try to follow perhaps even traditional approaches through acute care and 911 EMS.
Any other questions on this? Any comments on this side or questions? No? So first of all, I wanted to just say thank you for bringing this to us. I think this is really very interesting and very exciting. I just had a couple of observations that I wanted to make, and some, perhaps are worth us just thinking about a little bit more. First of all, I have become convinced that we don't have a very good process now for connecting patients necessarily with family members in moments of crisis. I think that's particularly true where we have adult mental illness, where they may have a family network of support. And I mention this because we are now in our foster care system investing in early family finding, meaning that we're looking for family members that we can connect that child to. And I want to make sure that whatever systems that the county is developing have a family finding component to them, because I think a big part of keeping people out of systems is really not even letting someone wander off by themselves, but if they have any kind of family member, that we're at least doing our best to connect them, and that we're keeping a record of that. So when we, for some behavioral problems that people have, the road's not straight. I think I've shared with you all that I grew up in a household where my father was an alcoholic, and there were times he was very stable and times that he wasn't, and his road to recovery was absolutely not a direct path. So recognizing that, how do we kind of keep that information? The second thing I'm interested in us diving in deeper, as we think about the future of our EMS contracts, we have multiple types of contracts relative to EMS. We have the emergency contracts, and then we have contracts where we're moving someone from point A to point B midday. It could be from a home to a hospital bed, one hospital to a step-down facility, and all of that. And then we also have our emergency program for youth, and that require a 24/7 response. And we also use an ambulance to transport young people from the home to maybe it's Uplift or maybe it's to another facility. And so understanding how we leverage all of those systems in terms of how we train people and what the appropriate protocol is, irrespective of who ends up on the doorstep, I think is very critical. And I wonder if that's something that you've already taken a look at in the pilot.
Not in the pilot yet, but I think where you're going is important. There are many layers of EMS. In the pilot, we're talking about 911 EMS specifically, and that's where there are some statutory limitations. When it comes to private sector and non-911 transports, there's a little more latitude. In fact, there's a lot more latitude in terms of destinations, both origination and where they're going. So that part is, in some extent, a little bit easier because there's less limitation on what can be done, and it's after all, pretty much probably on a physician order transfer from point A to point B. The challenge lies in 911, I think, mostly in perhaps the hyperacute phase of behavioral crisis. So if we can take those thoughts and address that to 911, start there, then subsequent care that is now organized, and physician directed, and when there are largely now interfacility transfers, that's a little bit easier and easier to work with.
Yeah, and I recognize this is an onion that needs to be peeled, and I'm pleased that we have both the chief from Santa Clara and the chief from San Jose, because I also think that if we really want young people in particular, but anybody who's having a challenge to be able to get the kind of support we think they need, then having the appropriate response out of the box is, you're right, I think that's really critical. And it's one of the reasons I've been really focusing our communication system on being able to do video communication, so that we're not just dialing 911, but we can show the dispatch center what we're seeing, because I think that would help them do a better job of helping us make calls. I've called 911. I live downtown, so I get to call quite a lot, and I'm always overwhelmed by the response, and so often I've known, just because I've called and lived downtown a long time, and I guess as I'm getting older, I feel like I'm getting wiser, maybe older faster than wiser, but nonetheless, that I wanted to say, I just need an ambulance, or I just need we have a woman who really needed to go to EPS, and one of my neighbors works for the county and is a doctor, and said, oh, she needs to go to EPS, and we have all the wrong response, a lot of it, but not necessarily the right response. So this is really exciting. I'll just make one last comment, and this is really more for the staff. It's interesting to me, one of the challenges I think for Gilroy is it's just so far away, and I think the same in Palo Alto, and with traffic and other things, I think people are going to make decisions based on convenience as well. And I don't blame them. I mean, I think part of what we want to do with these systems is we want to make the police available to those emergency calls, and not be in transport when those calls are happening with somebody who's not, frankly, a risk to the public. But I am really interested in what opportunities there may be with our purchase of St. Louis, and also the DePaul site, relative to placing services closer to that South County area. And just hope that as part of as we're doing the assessment, I'm really saying this to the staff who's working on these, the integration of services, as we're doing the assessment of opportunities out in South County, that this is a big part of what we're hopefully going to be taking a look at, making available at St. Louis. And I don't mean in the medical, I don't mean in the emergency room. I mean recognizing that we have property there now that gives us an opportunity to create alternatives to those, and maybe even strengthen the urgent care out there for these kinds of calls. So anyway, those are my thoughts. Thank you, and you'll be back to us in, Gary, can you, you have one more year of a pilot. When would be appropriate to just sort of update us on the next steps, especially if there's a legislative component? I think that many of us here, we're all sitting on committees that are in Sacramento that we could be helping, I hope.
I think in about 6 months' time, we would have more sufficient data to kind of drill down and give a deeper report on, if that's okay to the committee.
That would be great. And then also, if you could let us know at that time a little bit about where it is in the legislative process also, so that we can all be active in that.
Yeah, our legislative analyst is tracking this closely and giving me reports as she gets more information.
Who's the lead author? I'm sorry that I didn't look carefully enough to know that.
Do you know who the author is?
Who's the champion of this?
The AB.
Oh, I do, but I'm blanking right now. I'll find it for you.
That would be great. Maybe
you.
just
Sure.
get that to Maya. It might be someone we can stalk
Sure.
as well. In a legal way, I say, in front of the judges. All right. Thank you very much.
Sure.
All right, thanks. And we'll move on then to item 5. And item 5 is to receive a report from Custody Health Services relating to inmate access to prescribed medication upon release.
All right, good afternoon and happy holidays, everybody. Matt Guerrier, Executive Director for Custody
Matt,
Health.
I'm going to ask you to lean in. Just
Lean
like
in a
pull
little,
that
okay,
mic. Yeah,
there we go.
better. Thank you.
Better. So first, I'd like to thank Supervisor Chavez for leadership and helping us try to improve access for essential medications for our patients, and we're taking solid steps in trying to improve access for the patients as they're released. Custody Health Service has been working with County Council, the Procurement Department, and Valley Health Plan as advisors on a contract that would provide inmates who are being released with timely access to medications, essential medications. What the contract does and what this company does, the company's name is Navitus, and they help coordinate access to meds for insurance companies is their primary job. They have been helping us, and what they have access to are 78 additional pharmacies across the county. So the folks that are being released would have access to 89 pharmacies that include Walgreens, Costco, Safeway, Albertsons, and then several independent pharmacies that are in the county, and the pharmacies are throughout all of Santa Clara County. So we would have access from Milpitas to Palo Alto to Gilroy and in between. There's also several 24-hour pharmacies within about a 4-mile radius of the main jail, and there's another one that's within about a 5-mile radius of Elmwood. We're working on several ways. I know when I first presented this, we thought we were going to have to issue cards and do several things like that. Through our discussions with Navitus and with Valley Health Plan, we're getting that much more streamlined, so we're still in the negotiation process for the contract for that. So at any time they can pick either one of the pharmacies and tell us which one is closest to their home, or they are always welcome to go to any of the Valley pharmacies and they'd be able to pick up their prescription. We're looking forward to piloting this. My apologies for it taking a little longer than I thought, but this is both a new contract set for Navitus itself as well as for us. So nobody in the United States or anywhere in the world actually has done this before. But through the contract, we're going to have to, we will be able to give released patients improved access throughout the county, obtain their essential medications, and again, it gives an additional 78 pharmacies on top of the 11 VMC pharmacies that are already available. And with that, I can take questions.
Judge Manley, I could.
Have we ever resolved when the defendants are released?
Yes, sir.
I had suggested that they be given enough for medications. I mean, I see so many people that have to take them every day or they just cannot make it. That they could be released with sufficient medications to tide them over until they can get bridge medications or a refill at a pharmacy. Did we ever resolve that, or did you ever resolve that? I think you said something about the county council, so there was a liability issue. I didn't ever fully understand.
So there is a liability issue because it has to be issued from an outpatient pharmacy, which the outpatient pharmacies are the ones that are at the Valley clinics. There's one at the Valley Specialty Clinic. There's Lenson, which is the one we've traditionally used for released inmates, but Lenson's not actually on a bus route of any sort, so it's a little bit more difficult to get to Lenson. With the start of HealthLink and the modules that HealthLink has, the electronic medical record, anybody that has a prescription through the system is able to go to any of the county pharmacies to start with now, and that's actually still in place right now. And then what this will do is they'll be able to go to any of these 78 pharmacies. They have to tell us which one they want that's close to their home, and then we send the prescription there. But they could also still go to one of the Valley clinic pharmacies. But there has to be an outpatient license for that. There's several steps to go through, which is included in the ledge file that I sent. So, and the other liability to it, sir, is that there's the 340B pricing that has to do with the safety net hospitals in California, which is quite a discounted set of you can get the medications for outpatient prescription at a extremely discounted price, and that would possibly put that at risk, is what County Council tells me.
Any other comments or questions? No? So, I just want to say I'm excited, and really, frankly, we've got to try, right? This is where we're in the mode of really trying and learning. And I will say that as we move forward, we can have regular check-ins here, and I know that. I want to make a couple points. One is that I think this is true for reentry in general, but I feel like I say this about every other meeting, that getting where we're going always feels like it takes longer than it should. Honestly, I know all of you who do this work feel the same way. It's funny when people yell at us about red tape. I always want to say it's not us, but sometimes it is. But frankly, but I do think as we move forward that learning everything from under what terms and conditions people really will go pick their medication up, and then working backwards from that as a learning is going to be really important. So both in terms of the numbers of people we're helping, but who accesses it, who doesn't, is going to be a really critical discussion. And then what does it take? So one thing I would like to just recommend, and maybe, and I'm kind of looking at Gary and Miguel for this, because I kind of wonder if it makes sense for us to figure out a way to do some follow-up with people who don't pick up their medication, and be able to do some interviews with them, and then some of the people who actually do pick it up, like why did they do it versus why did other people not do it? I think that's just going to be something that we're going to have to kind of dig into. And I know it's difficult to talk to people once they've decompensated, so I realize what I'm asking is it may be us interviewing a family member or someone else.
Yeah, certainly. We've been talking about this as a reentry center, about doing some more outreach and focus groups with folks, but I'm thinking more of like when they come to the reentry center, maybe put that in our questionnaire.
That's a great idea.
And I can have discussions with Javier about that. So.
Great, thank you.
I think follow-up, as you suggested, Supervisor, from distinguishing those who never pick them up and why is really important, like going from that standpoint to rather than we're just making them available, will help us in the future.
Focus, great.
Okay.
Matt, thank you. We'll look forward to more information and more good things. Really appreciate it. I know that was not an easy task. Okay, great. We're going to move on to. Oh, yes, Matt, did you want to say something?
No, just thank you. And happy holidays.
We're going to move on to item 6, and this is to receive our report from the Office of Reentry Services relating to the Adult Reentry Strategic Implementation Plan. Wow. It's not even Friday. There you go. Welcome.
Good afternoon. Javier Aguirre with Office of Reentry Services.
Nellie Lee, Office of Reentry Services.
So we're really excited to be here to present to you the Adult Reentry Strategic Plan, or Implementation Plan. We started in this journey with Reentry Network back in April of 2017 with our consultant, DC Design. They facilitated some working groups with the Reentry Network, and we've come a long way. So our goal was to simplify our presentation through a PowerPoint presentation and also with the one-page executive summary. That's all been attached to your document. So I'm not going to go into our mission and vision, but just wanted to highlight that our focus of this implementation plan has been client-centered. So all the work that we are promoting at the Reentry Center in our collaboration with our community partners and our county partners is around serving our clients. As I mentioned, we have been working with a lot of the staff and community members in building this implementation plan, working with our 4 working groups, and they're excited to continue the work as we move forward with the implementation phase. We've had strategic planning. We brought this some findings to this board back in June, and then in August when DC Design presented their findings. So today we are now presenting to the Reentry Network our implementation plan with the hope of getting feedback from our members today, and then we'll come back with our final implementation plan in February. And our goal is then to submit the plan to the board subcommittee, the Public Safety and Justice, with the full board approval in April and May, and this plan will then go into effect on July 1st of 2019. So during this whole process, we wanted to make sure we identified the strategies, then moved on to the objectives, activities, and measures, and finding some measurable results that we can all be proud of in terms of what we've done in the next 3 years, implementing our strategies and ensuring that we meet our mission, vision, and guiding principles. In your packet is the full implementation plan. Just wanted to identify the key strategies. The first one, of course, is serve the client, strengthen collaboration, sustain public safety, and steward operational excellence. Again, our focus is on serving the client and how we promote services, but not only that, but also how do we streamline screenings, assessments, referrals, and triaging our clients as they move along from point A to point B. This slide depicts our 15 key objectives. The big understanding is that what we provide at the Reentry Center, some of our 5 key service domains, but most importantly, how can we assist our clients in terms of pathway to employment and with fulfilling their educational needs. So and here's the slide of just some of the objectives, and wanted just to discuss a little bit about serving the client. So over the last few years, we've been serving about 5,000 individual clients at the Reentry Center. Many of them come to the center several times. So when we look at the big pictures, how many people do we intend to serve over the course of the 3 years? You know, that all depends on the various programming that is offered, the capacity of services that are offered by our partners at the Reentry Center. But we believe that we're going to be surpassing the 5,000 a year. We have an RFP out in the community to seek new proposals for reentry services. And if all goes well, we have those contracts in place on July 1st. We anticipate serving about an additional 7,000 annually unduplicated clients who will be receiving service linkages, college courses, employment, social psychoeducation, legal services, and legal workshops. But most importantly, Reentry Center is one facet in reentry services. Behavioral health services receives about $5.8 million for mental health treatment services in the community, and an additional $3.5 million annually for substance use treatment services. So we leverage behavioral health and also serving our clients. One aspect of our objectives is sustaining public safety. So working with our law enforcement agencies, our partners with the sheriff, probation, pretrial, identifying the clients that we want to serve, and then also, of course, doing appropriate triaging. The clients that we serve come to the center dealing with mental illness, homelessness, drug addiction, and what we try to do is try to serve them as best as we can. We do the initial registration, the assessments, and screening, but it all is based on the capacity of our service providers. So for example, if an individual is seeking housing, they get a VI-SPDAT. So it's a screening tool that Office of Supportive Housing uses. They get in the community queue. Hopefully they get into permanent supportive housing. It does take time. A lot of clients expect that once they come to the center, there's going to be a housing slot available for them and a key to that room or that home, but they understand that it's going to take some time. So we work as a collaboration to identify their needs and then place them in the right housing program. We work closely with behavioral health, ensuring that they have outpatient program and transitional housing unit. If individuals are coming for behavioral health services, many are being screened by the clinicians at behavioral health unit. And then once they're screened, they could be enrolled in outpatient crisis residential, intensive outpatient or family or a full service partnership. But again, it's all based on capacity. And behavioral health is working in terms of expanding the capacity beginning in fiscal year 2020. The measures that we're identifying is looking at the standardized assessments. When we did the journey of a client, we identified over 14 screening or assessments that a client may undergo from being in custody, coming to the reentry center, then being referred to a service provider. So that's many screenings and assessments that we may be duplicating the same questions. So we're trying to analyze that and see if we could all come together to share some of that information. And of course, the most important is the data sharing agreement. So we can't be successful without able to share information among partners. And then I understand who needs the services immediately upon discharge from the jail into the community. So we work closely with Custody Health and the Office of the Sheriff to identify those clients. So at the end of the day, so after 3 years of this implementation plan, what do we expect to celebrate in 2023? And so we have some laudable goals in terms of what we try to and attempt to achieve. And the first is safely reducing the jail population by 500 over 3 years. The board in June approved a grant to the safety challenge through MacArthur Foundation, and that funding request was to reduce the jail population by 500 if we do jail diversion and other services. So we think we could do that over the 3-year span. Decrease the AB 109 targeted population recidivism rate. A few years ago, we did a study over 5 years, and it identified them as recidivating at 45%. We're hoping that after 3 years of implementation, looking at AB 109 population would be at 40%. It's very important that as we move forward, we address and reduce racial and ethnic disparities. Looking at numbers from years ago, the Latino Hispanic population is still at 52% in jail and receiving services, and with 25% of the general population. So how can we reduce racial and ethnic disparities across agencies and across systems? The fourth goal, that over 70% of our clients that are receiving employment services retain their jobs for more than a year. We've had very success with Goodwill Industries and Catholic Charities, and as we move forward with the new proposals, we want to make sure that all of our providers meet that goal. And then finally, that over 60% of clients receiving AB 109 funded mental health and or substance use treatment successfully complete the program. So that's working very closely with behavioral health, and there was a talk or discussion about interviewing and doing focus group with clients, making sure how can we understand why clients leave treatment before they complete their program. And then just finally, always is very important for us to look at funding outside of AB 109, outside of general fund and Measure A funds. And so the state will be releasing a request for proposals for Prop 47 funding next month. And so we're working closely with our Chief Operating Officer to identify a task force, a working group. Many of you will be asked to identify some of your staff. And then we'll be working with our grant writer so we could be competitive in securing additional funding from the state for behavioral health needs and to reduce our jail population. So with that, I welcome questions or comments. Thank you.
For that presentation and for the report. Any comments or questions? Yes? Can you turn your mic on? Thank you.
I'd like to make a comment regarding our partnership with Reentry Services and South Bay Consortium for Adult Education. If you don't know what is South Bay Adult Consortium for Adult Education, this is a direct result of AB 86 and AB 104 legislation to overhaul adult education in California Community College, California education system. So consortium has 4 colleges and 5 adult schools and roughly about 30 community partners. Reentry Services is one of the community partners. We try to offer educational services to different populations. I passed on a handout. It has a 2-sided handout. This is the one you're looking at, emerging model. That's our 400-page plan into 1 page, if you're looking at it. These are the services we provide, and we identified in the middle, if you look at the top, leaving incarceration. So this is part of our plan. So our plan and your strategic plan kind of aligns to how educational relationship and providing educational opportunities for our clients here. So I wanted to acknowledge Javier, Nelly, and Dr. Marshall, who have been working with me for a while. We kind of drafted on the back of this handout, you'll see the services that we can bring to Reentry Network. So we kind of sketched a plan here with what we call educational and other services such as financial coaching, life skills parenting, assessment services, transition services to colleges and adult schools and all that. We kind of mapped out. Just wanted to give you a little update on what's happening regarding this education partnership work.
Great, thank you.
So on packet page 21, objective number 5, services tailored to meet the individual needs. In my mind, I assumed that this meant also taking a gender responsive approach, but I just wanted to make the recommendation to communicate that in the plan because I know it's something Santa Clara County is doing, more specifically the Reentry Center with GROW, and I think that's really awesome to communicate that we are being intentional with meeting the needs of women. And then another recommendation I wanted to make was for the housing piece, in particular for young adults, is maybe thinking about family reunification services, because I know personally I burned a lot of bridges getting to jail. And so I was facing housing instability myself, and it was, so I just think it's important to think about family reunification and maybe mending those bridges before you're out of custody. That way they aren't facing housing instability upon release. And then,
Amanda, can I just stop you? Could you respond to that point?
So regarding the gender responsive,
Javier, let me just stop you on the first point. I'm assuming we're doing that. We just got to embed it. But on the second point, could you dive
family
into that?
reunification?
Yeah.
So I know there is the board approved a referral for us to come back to discuss about the parenting classes that are offered at the Allenwood Main Jail and also Reentry Center. So we'll be taking a look at those to see how more we can do with family reunification. We used to have service providers that were specific on family reunification, and were not successful. And so we are now taking a different look through client navigation. So part of our RFP is looking at having peer specialists and peer navigators to assist the client to brokering those family reunification. And so we're hoping that through those service providers and our community workers and peer mentors, we could have that dialogue and have that family reunification discussed.
Go ahead, Amanda, I'm sorry.
And then I also had a question on packet page 35, number 4. It says each client will have the opportunity to create transition plans. I was wondering if this would be available to everybody, even if they don't have a release date, including maximum security folks.
So that is our goal, is for each client exiting jail to have a transition plan. Now, what that entails, there are a lot of site and releases that are there for a few days and then go back into the community. But I think we're going to start with our current transition discharge planning efforts that we work closely with custody health to identify the high risk to reoffend. So those are the plans that we already have in place and working closely. How do we then put that into our referral tracking system so then we can work collaboratively and through case conferencing. After we complete that phase, then we're going to look at another segment of the population, and you mentioned GROW, so now it's working with the women at Elmwood to see if we could work with transition plan. A lot of our community partners are already doing some transition planning, so now we want to see if we could streamline. And then working closely with the Office of the Sheriff to then identify another subgroup of the population, and then we could see how that works in terms of transition planning.
Just on that point, let me just say, I think that our objective really should be, as people come in, that we have a way to get them out. And the challenge, I think, that Javier is pointing out, and I know that the Department of Corrections has made this pretty clear to me, is that the number of people that are coming in and out and the overall length of stay, like all of that is really valid. And so in some ways we've been pulling small populations. I think, in fact, AB 109 really allowed us to learn while we're doing. I would just like to add to this that when the final work plan comes to the board, one, that we're incorporating responses to the issues that have been raised today, but the other is that by that time, between the Department of Correction, Reentry, and kind of all of our partners, that we have a much better sense of how we're going to be doing the reentry kind of strategy, the discharge planning from how, from when someone's been in, when they're in our custody, and we know there's a possibility of them coming out. So really, how do we expand it in the most concrete way? Like, what are you all thinking? And frankly, to be direct with us about when that's, what populations we don't think that's going to work with, because in some ways I think you all understand the populations that we have in custody much better than I do, and some of the numbers are a little hard to understand in terms of who we can prioritize, how we prioritize them, and then therefore what does that mean both for reentry as an internal set of activities as well as an external set of activities. Thank you. Chief?
Yes, I just had a question. Thanks for the report. If I understand you right, you said 70% of the clients complete the drug program. But what I was curious about is when somebody is referred to a particular service, do we know the percentage of the follow-through, or if there is a handoff, if we know they actually went through the program, or if they successfully completed the program, and if they didn't, why they didn't complete the program? Because it sounds like we're making a lot of referrals, but I was just curious if there's any follow-up to see if they've actually attended or completed the programs.
So just to clarify, so it is our goal at the end of the implementation plan to have at least more than 60% of clients completing. We've been working closely with behavioral health to successfully implement what we call CAPS, the Community Awaiting Placement Supervision Program, where clients are either directly referred and picked up by a provider from jail into their treatment program, and then those that are in the community awaiting for placement. We are still working in terms of identifying the clients that have failed and doing some interviewing and doing focus groups. When we had our focus group, we didn't pull any individual that failed treatment. And behavioral health has a consultant, Resource Development Associates, that is kind of also looking at that question. So we'll be pulling that information. But I think the key is, and it was alluded earlier about, is surveying and asking questions up at our registration at the reentry center. but also doing the follow-up with our providers and looking at how many clients made it to their door and how many failed, and what some of the reasons. Is it transportation? Is it the safety? Is it the location? Or the modality of treatment? Many are placed because their parole agent or probation officer says this is a requirement, and perhaps behavioral health has a different assessment. So just taking a closer look at that, but we'll definitely do that.
So Javier, just again to follow up on that point, what is the percentage of people who successfully complete the programs that they're given through reentry now?
So when we spoke with behavioral health, currently it's 50%.
And so, and we're going to try to move it up 10% in the next 5 years.
So we're going to try to do it for the AB 109 funding for over 3 years.
Okay,
Yep.
but up 10%?
Correct.
And it's just AB 109?
The AB 109 funding.
And, you know, and one other thing, and I know Gary and I've talked to Aaron a little bit about this, we've had a lot of people pitch us on apps that make it easier for clients to manage their services. And I understand that there's an app that I thought the Public Defender's Office was using now. Is that accurate?
We are not using an app, but there is a notification system that Gary Hersig and I launched through ISD, now TSS, a few years back, but it's not as robust as some of the apps.
So
yeah, I've strongly supported that, Supervisor. As a matter of fact, Contra Costa County's having real success with it.
Yeah, I know.
To me, it's common sense that we should be moving in that direction.
Right. So what I would like to suggest is that I know Gary, that my office is trying to connect with you and with Dr. Smith to just kind of take a deeper dive. I hope, Aaron, with you actually into this. But there are kind of two different ways I've been trying to look at this. One is getting services to a person who's ready to receive them, who wants to use the app the way you would use a Fitbit, right? And especially just given the sheer volume of classes and support, I'm putting that in quotes because they don't all think of it that way because they're being pulled in so many directions, but for someone to be able to actually manage their own services, whether that's sobriety or whatever. And then the other is just our ability to track the volume of human beings, the programs we're putting them through, being able to, in an aggregate way, assess dosage, approach, program, and all of that. And at some point, it's not on our work plan, but at some point, I would actually like to have a wrestle down discussion here about what we currently use, what's available in the public, under what terms and conditions we would choose one over the other, and then see whether or not it makes sense for us to do an RFP. And the reason is, at least with two developers, software developers, I feel like I'm literally talking to, I don't feel like I can get a picture, and I feel a little perplexed, and I would like to not be perplexed, and I'd like to see if these tools could be helpful to us.
Sure, we can research that and bring it back to the committee. And also, just a note, you mentioned tracking. The reentry's referral tracking system is going to be live on January 3rd. So we'll be able to track all the referrals, and the CBOs will be able to access that system and give us report backs on how they're doing at the treatment program. So that's been 3 years in the making, so we're kind of excited about that, and just reviewed the final information with County Council a few days ago. So
would you, maybe what we do is for the next meeting we have, let's just look at that live. You know, let's just see it,
Sure.
See how it's accessed, and be able to walk people through how the data is collected, you know, all of that. And that might be a good first step. And then the second step, I think, is really taking a look. We have so many people pitching us now that I am nervous that either we're going to not take advantage of something because we think we have our own and it's the best, and it may or may not be, you know, and maybe it is, maybe it isn't, I don't know, or that we may be missing an opportunity to really help clients be more client-centered in their ability to manage the information and the data and even their medical records. Like we want them to leave and be able to get a prescription And it appears to me, well, anyway, it's a longer discussion, but let's work plan it, and then let's have a deeper dive here.
Okay.
Aaron, did you want to jump in, and then I'll go to you, Judge Manley.
Yeah, I just wanted to speak to that because we launched our own app to try to help the clients do a lot of this on their own as far as checking in and their court appointments and things like that as well. One of the limitations that we have and the clients have is that not all of them have access to the devices that point out that we have some limitations there as well.
Yes, but I would also say that even the hardware component of these is becoming more cost effective. And so I'll just use the ankle bracelet. We were using until I don't know how long ago, and you had to have a hard line in your house to use the ankle bracelet. And that's just not the way the real world works anymore. And frankly, the other thing is I spend a lot of time, as you can imagine, because I represent the poorest people in the community, live in my district or a little piece of Mike Wasserman's district. And the number of people who have a smartphone is actually really surprising. And I think in part because in some respects the costs have come down. So I just want us to, even if we had to make those available, it can't be, it can't be anything but more helpful, right? And so, but I appreciate that. And Aaron, I appreciate that you're always thinking about it from the client's perspective, so thank you. Judge Manley? Oh, Key, do you want to jump in too? All right. No, after the judge.
Judge Manley might have a few comments, so I'll go first.
Go ahead, Judge Manley.
So
or
first,
okay, not.
Javier, Nelly, great job. I know this is a lot of hard work, a very complicated social issue, so appreciate your effort on this. I also like your commitment towards some very concrete objectives. I don't know how hard it's going to be to get there, but I think it's necessary. I wonder if we could spend a little time after the meeting talking a little bit about these, because I think there are sort of some assumptions or logic behind some of these objectives that we want to understand more clearly, so we can develop, a set of housing strategies that support it. For example, of course, part of my job is to make sure there are as few homeless people as possible. But let's just say, for example, that we find that housing assistance has no impact on recidivism. Let's just say, which is I don't think is true, but let's just say that. Then that really might change our approach, change our strategies around housing assistance and what we do around recidivism. So maybe a deeper dive between ORS and OSH might help us deploy the right set of strategies. Mm-hmm. Thanks.
Can I just add to that as it relates? I was actually going to make a similar comment relative to employment. And one of the things that I have asked, and I think Dr. Smith is really just thinking about the how to do this, is that we invest as a county a lot of resources in job training, and through CalWorks and SSA. They are really producing a lot of. So anyway, I want to make sure that part of the shop gets a chance to review your work plan and see what their role can be in a much more proactive way, even including how it's developing some of its training programs. And the reason I was raising that I'd had this conversation with Dr. Smith is that housing affects the health care system, it affects the public safety and justice system, it affects SSA. Employment has that same sort of challenge. Each of our departments actually needs to access the very best kind of approach relative to health, safety, and wellness, but in particular for reentry and SSA, it's an area that I want to make sure we've talked a lot more about and we've wrestled through, in part because we have to wear our hat both as a trainer, as a contractor, and as an employer. And thinking that through with a much more strategic eye as to how that impacts each of the programs that you're running and that those that are being run in SSA, I think just need to be combined in a way that I'm not sure we've done yet. Unless somebody's done it, I just don't know. Maybe that happened. Has that happened?
So we're currently working on a employment program through the county executive's office and working on bringing in a consultant to help us with that.
Yeah, and I think that's as part of it, as part of some of the changes that we're making in SSA.
Correct.
So yeah, and so I just and are you taking a lead on that, Gary?
Martha and myself, yeah.
Oh, good. Oh, good. Then it'll incorporate. I would just make sure that is if we can do some conversations with the other side of the house. You know,
Sure.
That's great. Sure. That's really good news. Yes, I've been stalking him. Oh, that's so good to know it's happening.
And if I may just add too, we have a good partnership with San Jose City College. So they are teaching about 20 students at the Reentry Center to get a peer support certificate. And those certificates can help them with entry-level positions at the county, usually a community worker. And so we're working closely with ESA to look at the community worker classification, to look at it, to make it step level, because we're losing a lot of our community workers to higher paid jobs in the county. So we're working with the South Bay Consortium and building up our triage into employment. We want to make sure that all of our clients can apply to jobs here at the county.
Good. And we should be thinking, I mean, here's the other reason we're looking at the consultant, and I would just want to make sure we encourage this, is that we have to remember that we have, oh goodness, I think I counted this once, with all the special districts that we have in the region and all the jobs that we have available and the amount of money that is available for new hires in the public sector, it's billions of dollars, but we're not connected to all of them. So we both need the community colleges on the training side, but also on the hiring side. Water district, there's just a bunch of them that we haven't taken advantage of. In fact, someone here even suggested we start our own journey person program for construction. I was like, no. They exist already. Don't start anything new. We don't have to. Let's go, to the community colleges, the building and construction trade CET, right? We're already paying them to do this. So good. Thank you. That's really exciting. All right, Judge Manley, you're on.
Okay. Well, I'll try not to repeat what you've already said. I agree with it. And Javier, this is really a good report. I just think that I think the chief raised a really good point that we need to understand and more carefully define. I see this every day. Engagement, re-engagement, staying in treatment, and you don't complete a program in 1 year or 6 months. It is not just like you go to this residential program and you complete it and you're cured. There's a process that can take more than a year, it can take 5 years. The point to me is, are you moving in that process as opposed to dropping out at an early stage? And I think it's not a good idea to set a goal of 60% unless you define what you mean complete the program. Because people don't complete programs, and it's a reality that I see every day. So I just think we need to think more about that. I also, I think the employment is really now far more important. And I just want to have a quick question. When you say 70% will retain, are you referring to also, I'm talking about mentally ill clients, those who have part-time employment like Goodwill, Starbucks, where they're working maybe 20 hours a week, as opposed to somebody working 40 in construction, or 50 or 60.
So this 70% of clients receiving reentry support employment services, these are going to be looking at our contracted providers that...
Like Goodwill.
Yep, like Goodwill. Currently, Goodwill, Catholic Charities, and Conexión with their day worker program, to see if they provide the efficient training, say, over 3 months, and then they place them into a job, whether that's within the organization or out in the community. Have they provided the support that that individual needs to retain that job for a whole year? So it could be part-time, full-time. So we're going to be working closely with our providers to set those goals and expectations.
And that's just your providers. For example,
Correct.
The CEO program, Caltrans.
That's through probation.
But you're not going to work with them to...
Well, we definitely are learning how they're working with those contracted providers, and we could certainly work with probation to see how they measure the outcomes. But here, it's only those that we have oversight and control of the contracts.
Okay. Add something to that, but I think the point that with Gary and Martha taking a look at all of these programs, that my expectation is that they're going to have a conversation with probation along with SSA, all of our different departments, because really what we're trying to do is align all of this work.
To put it
Yeah.
all together.
Yeah, yeah.
All right, finally, real quickly, I have noted of late, not of late, for a number of years, that it is true, we have rapid flyers through the jail system in and out. We also, I find that in utilizing in-custody programs, so many of the people I see every day have actually made strides towards getting high school equivalency, adult education. They're getting scores. They're taking these classes, and that's one group. All right. Now they may never finish them because we're out of jail in 60 days. I'm trying to get them out of jail because, they've served their time. They're stable and we're moving forward. Then there's a group that I see, mandatory supervision, for example, or violators of PRCS, who are serving substantial periods of time in treatment programs, but not really. There's no discharge that follows that up. It just seems to me that if we did more work on trying to start the discharge plan from the day they go in, so that we were offering, and that would mean working with corrections to be offering classes. I mean, it disturbs me when someone, I have a number of people that are serving, let's say, 3 years of an MS sentence in jail, and then 3 years of mandatory supervision, and I monitor them, they're mentally ill and all of that. But they're not doing anything in the jail that I can figure out. And it would just seem to me that group of people could probably get out, because when they get out, they're going to community college. I mean, it amazes me how many people take advantage of this who are seriously mentally ill, but I don't see, that we're really following this or making it easier for them. They have to do all the work. They have to be pushed, And I would just suggest that we back up and maybe take a look at who we can work with coming out of the jail and divide them up into different groups, as I think has been suggested.
And I think what we need to do is share with you the report that the County Executive's Office and the Sheriff presented at the Jail Reform Study Session, where it laid out 5 Keys Charter School that is now doing programming in jail, and they saw an increase of folks taking that class. And then 5 Keys is looking at a facility in the community to continue that work. We're working closely with our community college partners to then, as clients come to the center and assess for education, that if they started in custody and they want to complete it, how can they complete it through adult ed in the community?
I just think it's important, and I think it's important that you make all of this available to the courts, because judges can motivate people, and it seems to me, all right, now I'm going overboard. Judges can do their best
You
to
motivate
at least
me,
make
Judge
them
Manley.
aware that, that this is available to you. We don't want this to spin around again and again, and I just think we waste, so many of them do so much work in custody, and then when they get out, they do nothing. And I'm saying, well, why aren't we connecting this? And that's,
Maybe what we can do is let's agendize the discussion on employment very specifically in education. And we were going to talk about the work plan, but you've already changed it a bunch, Judge Manley, so today. So I'll put that off. But no, I'm teasing. But in any case, let's just front load that because these discussions are really prescient. I mean, like a lot of us are starting to try to figure this out. So let's just make it next meeting. Yes, Aaron, and then I'll come to Miguel.
A couple,
and then I'll come
most
over to
of
Cora.
the desired results, they're quantified. And I would encourage us to go ahead and quantify the creation of strong policies and procedures to reduce racial and ethnic disparities, because that's a process, but we know how, the overrepresentation of people of color and kind of the purview of you is small. It can't look at all of it, but we really need to put a stake in the ground and try to do something about it. Another question for you. Do we have enough data to know if engagement in services is a decent predictor of outcome success and recidivism? Because if we do, we should probably have a measure just for engagement.
No, we don't. It certainly helps to get them there, but it hasn't been proven to make them stay there longer. We continue to hear the stories of absconding within the first 48 hours. So we do the warm handoff, we get them there, we get the warm handoff from the jail to reentry to the program. But then there's, and I gave a report to this committee, I think last time or the time before, about the different things that clients engage when they get to the program. There's someone there that they don't like, or there's someone there they had a conflict with in the past. They're not amenable yet to treatment. So there's a variety of reasons why they abscond. We haven't looked into if the program is meeting their needs to that specific level yet, but that's something we're hoping to do with the focus groups and so forth.
Okay, because I'll go pull that report up, and I apologize for not being as familiar with it. But I would say engagement isn't even necessarily if it's beyond the 48 hours. I mean, true engagement. So what's the difference of true engagement?
Sure.
And then also the definition.
Thank you. I just want to, recognize and, the terrific work that's been done so far on this plan. It's a work in progress, and especially, what Supervisor Chavez just talked about with respect to alignment and the continued work with ESA, the continued work with OSH, and our behavioral health and everybody else. It's a very collaborative effort that needs to be aligned, and I'm really pleased to hear the direction that we're heading. I had just one specific question, actually, on the measure of success, which I like, embedding those in. And the very first one says, client self-sufficiency and other applicable scores improve, which is terrific, but then it says sequentially. And I just wondered if you could, go a little further into what you mean by sequentially, and it may involve the nature of the work and the clientele that we're serving.
Right. So one of the tools that we use is the self-sufficiency matrix, and in the matrix, the numbers increase as the client does a self-evaluation of how well they feel they're doing, and so the numbers will go up. We usually will measure every 90 days, and so over the first 90 days, you might see maybe 1 or 2 point increase. The next 90 days, we're asking our contractors to use this tool so that you might see a higher score. And so what we're looking at is, there's not an exact, so we can make a measure, but we're trying to make sure that the score sequentially, number-wise, continues to rise until they reach a number that in this tool says that they're at a self-sufficient level. So that's what we mean by that, and we can probably explain that better.
Thank you. That's very helpful.
Yes, mine is just a general comment on how well and how hard you're working. I'm reminded that our main problem when we first started our journey is we couldn't recruit enough of our clientele, correct? Because essentially it's a voluntary service. I mean, they don't have to come. Now we're talking about problems in terms of how we deliver services and how we engage them more fully in the service once they're there. So that's a long ways, I think, from where we were before. I'd like to commend you for that, and also for all the collaboration that's happening now. You talk about capacity, right? We don't have the capacity to serve. I very much would like to have a concrete definition of that. What capacity? Is it a building? Is it the recruitment of professionals that can serve us? Is it services to the family, which we're now talking about and that we didn't have before, correct? Also, what we didn't have before are those services that are being provided in-house. We did not have those before, and we're starting on that now. I think that once we have a more definitions and evaluations of the measures. Now, because yes, we can have data, numbers. We need the numbers for sure because the law requires us to. But let's not forget that all those stories right? Those individual successes are also important. So those should be recorded or must be recorded as well. All right. Thank you.
So we have one speaker on the item, and that's Scott Largent.
Hi, good afternoon, everybody. I like hearing the conversation here at the end. I need to see more success stories out of this whole thing. I mean, I know I wasn't on probation or parole. I couldn't use any of the reentry stuff. And I've said that before. Where are all the success stories? Where is all the evidence that's showing that this stuff is actually working out? I know you're doing a lot of really good work over there, but in my situation, after, it's hard enough to get clean, and then when you try to figure out this whole mess of go here, go there, do this, the hardest part was just saying I wasn't going to do drugs anymore. When you kind of throw in that towel, and I see what happens over a period of, let's say, 6 months of being clean, you need more help. I mean, basically, you're tapped out. You probably more likely lost everything. You burned family ties. You're trying to rebuild your life. And it's very hard in Silicon Valley to do that. I mean, I was a business owner at one time. I was on a whole different level. Getting back to that level is going to be very, very hard. Not only am I trying to navigate staying off methamphetamines, so that's what makes it even tougher. And I think people like myself, we need somebody to hold our hand. We need somebody to show us, hey, you need to go there. Hey, you need to go there. And I don't think we're paying attention. I've come in here thousands of times, and in case you people don't realize, I was never able to get drug treatment. I was told I had to have meth in my system to go through detox. Then I was told after 3 months, Scott, you've been sober too long. And that Department of Alcohol, whatever it's called, they told me I was a high-risk person. I needed to be in inpatient treatment. It was immediately, you have to go there, and then they denied me from being able to go there. So here I think I'm doing all the right things, and they're like, yes, we need to put you somewhere. We need to get you in there, and it's no, we can't help you. And realize in 5 days I will have been sober 3 years, but I've never gotten treatment for meth. I'm a ticking time bomb to relapse, and I wish people would pay attention to the other people like myself, so thank you.
Thank you, Scott. Just a couple of comments that I wanted to make. First, I wanted to say to Javier and Nelly, it's actually amazing. It's an amazing body of work that you've done, and a lot that's been done under your leadership. And I want to thank both you, the two of you, and also the board members who've been on reentry since the beginning. I wasn't here, and I will just say that I remember having a conversation with Pastor Tony Williams, who's not couldn't be here today, but years and years and years ago about his vision around how reentry could work, and it almost feels like the state finally caught up with people who care deeply about other people. I also think that Scott's comments were very poignant. I think that we are a long way from providing the support and services the way we would like to. And I think it's important to have that kind of dose of reality today, because I think it will just help us provide programming in a better way. And like I've said to all of you, I try not to feel defensive when people tell us that what we're doing isn't working, because I think part of getting better is being able to hear that and say, okay, that's a reality, and what do we do about that? How do we proceed? And I think that's the way you've done it. You've done it with a lot of numbers and science and really trying to think about all of this good work. So when this comes to the board, I do want to just reinforce that the questions and issues that have been raised, that they're addressed in there. And even if the answer is we don't know yet, or we're not there yet, or here's where how we're going to take a look at it, that's all fine. I just want to make sure we acknowledge them. If there are no last comments, I want to say thank you and well done. Our last item is our work plan, and we changed it quite a bit today.
Madam Chair, I'm sorry, you do not have a quorum.
Yeah, I'm not going to have people vote on it. Thank you. Thanks, Michelle. What I would just wanted to recommend is that for those of you who haven't had a chance to look at it, if you could take a look at it, and for those of you who have, I'm going to just suggest that, Gary, that we do one more connection in January, take a look at this, and if anybody has something they want to make sure gets added, or report back that they want, or someone would like to give a report on the work they're doing, feel free just to let Gary know, or Maya. Maya's saying, let her know. Let Maya know. And Maya will just send a quick note out to all of you to remind you to do that. And most Maya, did you do most of this, the work plan? What a great response. Yes, if you like it. Well, so please feel free to give us feedback. We'll try to meet mid-January and kind of button things up for the next year. So if there's anything new you'd like to hear, let us know. I do want to say a really very sincere thank you to the staff who is doing this work. It's really hard work. I understand that. I don't do it, so I don't entirely understand it. And I also just wanted to say thank you to our partners around the table that are here. In particular, I wanted to thank Judge Lucas, and this is her last meeting with us as presiding judge. And just to say to all of you that you know our partnership with the courts is really important, and we really appreciate your being present at reentry, your being present on bail release, on all the other human trafficking, and all the stuff that we've been doing. You've just been incredible partners, and we haven't had a chance to say thank you to you and you know to our public safety folks as well. To all of you actually, but Judge Lucas, happy last meeting. So some other poor person will have to do it, but we've really appreciated our partnership with you. So happy holidays and have a safe time with your families. And hope you get a little bit of rest because we will only give you a little bit of time. Thanks, everyone.